welcome to this week's Case of the Week, Renal Angiomyolipoma. My name is Charlotte Lansky, and I'm a fourth-year radiology resident at Cedars-Sinai Medical Center. The patient is a 74-year-old Korean woman with history of hypertension and osteoarthritis who presented with an incidentally found left renal mass on a CT of the lumbar spine obtained for worsening chronic low back pain and left leg sciatica. She denied symptoms attributable to the left renal mass, including flank pain, abdominal pain, and hematuria. Shown here are axial and coronal IV and oral contrast-enhanced CT images through the abdomen, demonstrating a large, heterogeneous mass containing macroscopic fat arising from the inferior pole of the left kidney, denoted by the yellow arrows. It measures approximately 16 centimeters in craniocaudal dimension. The following images are taken from digital subtraction angiogram, or DSA. In image A, the left renal artery is selectively catheterized, shown by the black arrow. The yellow arrow in image B shows the multilobulated hypervascular mass at the inferior pole. Image C shows subselective catheterization of a descending branch of the distal left renal artery, shown by the blue arrow, which proves to be the dominant blood supply to the mass. Image D is a DSA of the left renal artery after embolization with ethanol and lipiodol of that descending branch vessel. There is an additional capsular branch, shown by the yellow arrow, supplying tumor vascularity to the inferior and medial aspects of the mass. Image E is a completion DSA of the left renal artery, shown by the black arrow, following embolization with ethanol and lipiodol of the capsular branch. The image shows greater than 90% devascularization of the mass with oil staining throughout the tumor vascularity. The normal renal parenchyma appears preserved with no definite non-target embolization. The final diagnosis is a renal angiomyolipoma. Renal angiomyolipomas are composed of fat, smooth muscle, and tortuous abnormal blood vessels. CT demonstrates a well-defined, heterogeneous fat-containing mass arising from the kidney. Angiographic images demonstrate a highly vascular mass with early arterial filling of abnormal tortuous vessels without aneurysms in this case. The differential diagnosis includes renal cell carcinoma. The key feature differentiating renal angiomyolipoma from renal cell carcinoma is fat content. AMLs are composed of fat, smooth muscle, and tortuous abnormal blood vessels. A fat-poor AML can be difficult to differentiate from a RCC. Features favoring RCC include large size, irregular margins, necrosis, cystic change, invasion, metastases, thrombosis, and calcification. Also included in the differential is retroperitoneal liposarcoma. A large exophytic AML and well-differentiated retroperitoneal liposarcoma may appear similar. However, AMLs arise from the kidney and demonstrate a parenchymal defect known as the notch or claw sign. A large retroperitoneal liposarcoma demonstrates smooth compression of the kidney. AMLs contain enlarged vessels, while a well-differentiated liposarcoma is fairly avascular. Take-home messages. Renal angiomyolipoma is the most common benign renal neoplasm and typically an incidental finding. AMLs are composed of fat, smooth muscle, and tortuous abnormal blood vessels which are prone to aneurysms and rupture. Most AMLs can be diagnosed on imaging by the characteristic feature of visible fat. Approximately 5%, however, are fat-poor and lack the classic features. Management depends on tumor size and symptomatology. Patients with AMLs greater than 4 centimeters, aneurysm greater than 5 millimeters, or symptoms, including palpable mass, flank pain, and hematuria, should be referred to urology or interventional radiology for prophylactic treatment. Treatment with transcatheter embolization, partial nephrectomy, or enucleation is recommended due to increased risk of hemorrhage in these patients. Thank you so much for your attention.